Good afternoon, everyone. Good afternoon. I think we need to bring the meeting to an order. Our session chair has arrived, and our panelists are already here. So to save on time, I think we need to quickly start. Please, if you are standing, just have a seat. So with your permission, Chair, I think we can just proceed. Others are still having lunch. They will join us on the way. I take this opportunity to welcome each and every one of you to Health Breakaway Session. This is our second session. We had one yesterday. Today we are going to have one on digitalization of primary health. The theme for this breakaway session is celebrating a decade of county-led health service delivery for economic growth in Kenya, but focusing on digitalization. So it will be a very constructive discussion. We want very constructive discussion, very active participation, so that we have very strong recommendation from this meeting that will be going into the communique, and that now will be implemented. So allow me to welcome the session chair, Her Excellency Governor Wanga. As she comes kindly, let us give her applause. She will be welcoming you and giving her a welcoming remarks. Karibu sana, Chair. Governor Wanga is also the Vice Chair of Health Committee. Karibu.
Asante sana, Katra. We have a very big hall. So if you're behind, maybe it's better to come to the front a little bit. Good afternoon to all of us. I think it's in this conference that I've seen people are not responding even when you say good afternoon. Thank you. And welcome to this session. I know that we're running quite late, so we will try and save on time. Dr. Sirengo, who's representing our PS for public health and professional standards, but is substantively the director for health sector coordination and intergovernmental relations. Harriet Kongin, who's representing UNAIDS. Madam Rita Okuthe, who's the chair of MTIBA. Mr. Peter Prickards, who's the CEO of MTIBA. Caroline Bindio, who's representing AMREF. Mr. Muyendo, CEO of the Christian Blind Mission. Dr. Susan Ontiri, Country Director, ICRH. Our health CECMs and chief officers and directors from our various counties, representatives of the Ministry of Health, representatives of development partners, representatives of civil societies, representatives of private sector and FBOs, distinguished guests, ladies and gentlemen. It is a great pleasure to welcome all of us to this momentous event under the sub-theme celebrating a decade of county-led health service delivery. On behalf of the Council of Governors, let me take this early opportunity to thank all of you for being here today and for your contribution to making this event a success. In the recent decades, the digital revolution has taken many sectors to brand new levels, and the health sector has not been left behind. Today, digitalization of health services is unmatched when it comes to its potential in increasing efficiency, effectiveness, quality and safety of health services in Kenya and beyond. Digitalization of health services gives a boost to many of our health sector targets, including our pursuit for achieving universal health coverage and sustainable development goals. In this regard, digitalization is an integral part of health priorities. But as we digitize health, we have to ensure that this is done in ways that are ethical, safe, secure, reliable, equitable, and sustainable, and follow the principles of transparency, accessibility, scalability, reliability, interoperability, privacy, security, and confidentiality. Ladies and gentlemen, county governments have been working with the national government and other stakeholders in the journey towards adopting digitalization and innovations in very many areas. These have included electronic medical records, telemedicine, electronic health information systems at community and health facility levels, logistics management information systems, and digital medical equipment, among other areas. Benefits of these investments have been many and include more accurate diagnostics, better treatment outcomes, better management of health records, fast information processing, more effective and efficient data analysis for decision-making, reduced cost of operations, and improvement in health sector resources. Simply put, digitalization of the health sector has resulted in efficiency, effectiveness, and also increased quality of health service delivery. As such, it is my hope that today, this forum will generate useful debate and make practical recommendations that county governments and other stakeholders can embrace. We want to have a debate that will not only generate ideas, but one that will ensure we improve our services to all citizens. As a council, we have put before you a panel of eminent persons to discuss this issue. And I thank all our panelists for attending and the keynote speaker for attending this forum as well. As I conclude, let me point out that in the last decade, Kenya's health system has undergone significant changes as it aligned to the 2010 Constitution that devolved health services and strengthened right-based approaches to health through providing that every citizen has a right to the highest attainable standard of health. The fourth schedule of the Constitution of Kenya 2010 vests the principal role of health service delivery to county governments, while national government is vested with the development of national health policies, standard setting, technical support for capacity needs, and national health referral services. Further, it is important to note that although health sector functions are assigned to both levels of government, much more success is realized when the two levels of government collaborate. The devolved health system has seen Kenya record marked improvement in health. For example, according to the 2022 KDHS, 9 in every 10 mothers who give birth do so under care of trained healthcare workers, up from 66% in the year 2014. Over the same period, the under 5 mortality rate improved from 52 deaths per 1,000 births to 41 deaths per 1,000 births, while the infant mortality rate improved from 39 to 32 per 1,000 births. Digitalization of health services can help us reap more results as we move forward. Finally, county governments remain fully committed to fulfilling the requirements provided by the Constitution of Kenya that guarantee all citizens the right to affordable and accessible quality health care. Let me thank you once more and reiterate our full commitment to work with you all in improving health outcomes for the people of Kenya. And with those many remarks, let me take this opportunity to invite to the floor Liz, who is going to be our moderator for this afternoon's session. Karibu sana, Liz. Asanteni.
Thank you so much, Your Excellency. I think she deserves another hearty clap. The slip I was doing there was just to jostle you up. You would have loved if I fell. It would have made good comedy, right? Just to lighten up the mood. Thank you so much once again, Your Excellency, Governor Wanga. Hello and good afternoon, everyone, and thank you so much for making time for joining us for this health sector breakaway session. The objective of this session is to discuss county experiences with digital health innovations and examine digitalization as an enabler to fast-track the attainment of inclusive, sustainable, and scalable universal health coverage models. My name is Liz Tonjira. I'm the Communications and Engagement Director at Women Lift Health and also the co-chair of the Zero Malaria Campaign Coalition. I'll be taking us through this session that is graciously chaired by Her Excellency Gladys Wanga, the Governor of Homa Bay County, and also the Vice Chair of the Council of Governors Health Committee. Now, we have a distinguished set of panelists who will be sharing crucial insights into this topic that we'll get to meet in a few minutes. But before we start that and before our keynote, I would like to invite a short video that will really help in the further framing of this conversation that we're going to have this afternoon. If we could have the video, please.
In Kenya, the health sector is gradually leveraging technology to achieve universal health coverage for all by 2030. Digitalizing is therefore an important aspect in fostering effectiveness and efficiency across all essential building blocks of a health system. County governments, in partnership with stakeholders, have invested in systems and solutions to ensure aspects of health services are digitalized and foster innovations. Some of these solutions available include telemedicine, Zipline, ECHIS, Prompt, Spice, MomCare, among many others. Through telemedicine, citizens can access specialized quality health services remotely. Patients at the facilities get access to specialized services through digital equipment, which ordinarily would not be accessible at their geographical areas.
So when the loader puts the package inside the payload area, it closes, and then it will only be able to open when it gets to the facility.
To increase efficiency of health service delivery, counties have embraced technologies such as the Zipline innovation to provide buffer stock to cover supply delays and stockouts and improve availability of blood. Other specific services include to stock and distribute blood routine vaccines, anti-rabies, anti-venom, and emergency drugs. ECHIS, or the Electronic Community Health Information System, is a standardized digital tool developed to improve community health services. In this system, community health volunteers use a smart health app that is installed on their phones. The app is linked to the supervisor app and to the dashboards. They collect crucial data in homes in a pre-installed format and send the same to the dashboard linked to the Kenya Health Information System.
I've been a volunteer for 11 years, working as a CHV. At first, we were using papers to report all reports. And now I find it easy when we started working with a smartphone. All our reports, I am reporting through smartphone, and it makes my work easier.
And 5 positive diagnosis yako ni chini. Assessments ni mingi.
The supervisor app enables close supervision of the community health volunteers, hence ensuring that they provide high quality services in the community in a timely manner.
In the previous version of the supervisor app, it essentially allowed the supervisor to conduct only in-person supervision, but not in a detailed manner, and much of the CHB performance was available on the dashboard. I'm happy to say the challenges are a thing of the past now. I'm able to see everything I need in one place. The supervisor app enables me to conduct remote supervision, view historical KPI for the community health volunteers, and provide personalized mentorship.
It also ensures that the data they collect is genuine. The data is used for various interventions and for decision making.
We have started using this data. Like right now, we have used this data to get the indigents in Kisumu so that we can be able to finance them.
A trial for the system has been completed successfully in Kisumu County, and the national government intends to scale it up in all the counties in the country. PROMS is an AI-enabled digital health service that supports millions of expecting mothers to reach care at the right time and place. Mothers like Beth. Soon after enrolling, mothers receive text messages relevant to their stage of pregnancy. Such messages include pre- and postnatal reminders. They can ask PROMS a question at any time and receive a personalized response. A single mother's journey on PROMS can reveal a lot about the clinical quality she receives, how she receives it, and any barriers she encounters in consumption of the services. But millions of women's journey can inform system-level improvements towards better outcomes for moms and babies. SPICE is a digitally enabled health system that was co-designed with patients, clinical health doctors, and community health workers located in underserved areas. It aids in clinical management in local communities.
I'll be able to view just at a glance on a clinic day when the patient is seated now in front of me. I will definitely see the blood sugar record on that day. If it is on the higher side or within normal limits, I will see the blood pressure, if it is within normal or within an abnormal limit.
With SPICE, I'll say I have a bigger platform to understand the patient holistically when they're actually sent to me. And I can read the drugs, I can read the triage and what is going on. By the time they're reaching me, the only thing I'll just need to readjust and do is actually the vitals.
Care workers use SPICE to screen, diagnose, manage, and improve clinical solutions of chronic diseases.
I think it's faster. I think there's more of continuity. You have your notes, your records in the SPICE, in the tablet. Even if the patient does not come with a book, you can easily access. So I think the experience is good. I like it. For future, I would recommend that we continue using for research and everything like that.
MomCare is a program that seeks to ensure all pregnant women have access to quality care without the risk of financial catastrophe. The MomCare model allows for expectant mothers and healthcare providers to follow a standard pregnancy program on one digital platform at a predetermined cost and quality.
MomCare is able to do this by instituting a digitally supported care model, really bringing data, transparency, and shining a light on which health interventions are working, and really giving the health facilities and the institutional pairs like county governments the capacity to act.
We ask our governments in Kenya and across Africa to invest in digitizing community health systems and resourcing community health workforce to deliver universal health coverage across the continent.
Without further ado, I'd like to invite our keynote speaker on stage to give her remarks. I'm calling upon on stage Ms. Rushika Singhal, the International President of Medtronics Lab, to come on the stage. Let's accompany her with a hearty clap.
All right, good afternoon, everybody, and thank you so much for this opportunity. It's great to be here. I have to say, watching these videos makes me feel, isn't it such a great time to be alive? I feel like in the history of humanity, what technology has been able to accomplish just in the last 50 years is unparalleled. and what we can do with technology over the next 10 or 20, 30 years in our lifetimes is unimaginable even to us today. I was doing a little bit of research and I realized it's been 50 years since the cell phone was first invented. Think about it. A lot of us were not even alive, but a lot of us were. And the first cell phone was 2 kilograms heavy. Can you imagine now these devices that we have in our pockets that we cannot go anywhere with? We don't know how to live without them. But the opportunity in front of us is that these technologies, we haven't really captured or even started to capture the potential for addressing one of the most fundamental rights for human beings everywhere, and that's healthcare. And that's what we are on the cusp of. And it's a huge opportunity for all of us, and it's so great to see the energy and enthusiasm around really thinking together how we can solve the challenge of healthcare access by leveraging these incredible tools that we have at our fingertips now. So, just thinking about it from a few different perspectives I wanted to share with you, really starting with the individual, the patient in a community. Most of us, we use all of these tools to search for information, talk to our friends, post photos. We can use these things and enable people in the community to use these things to get basic information about health. We saw some of that with the messages to moms. Why just moms? Why can't we do that for every condition that patients have? Whether it's diabetes or hypertension, how do you eat good food? How can we provide those nudges so that we enable all patients in our community to be able to take greater ownership of their own health? That's one idea that I think, building on some of the examples we saw, are immediate applications, really enabling patients in the community to be able to be informed and have the right information at their fingertips that's relevant in their environment and living condition so that they can make those modifications and have better control over their own health. You think about the next level in the health system, which is the community and the incredible community health infrastructure that is being built here. We saw some examples of that as well, leveraging smart tools so that community health workers are more empowered with the right clinical information. All of us have Google. Why couldn't we have a medical-focused Google for community health workers so that when they go see a patient, within certain guidelines and frameworks, we can just give them more information at their fingertips so they can provide better care to the patients at the doorstep? We give them the ability to triage who are the high-risk patients that really need immediate care that they can target their efforts at. Because we know there are a ton of patients and not enough resources that we're ever going to have. So how can we make it more efficient for these community health workers and give them all of the tools, not just inputting data, but really having all of the world's medical information synthesized and streamlined and contextualized for their setting. All of those capabilities exist today. We have to figure out how do we deliver and bring them. Go to the next level in the health system. So you start with the patient, you start with the community health infrastructure, and really then it's the healthcare delivery system. We all know how overburdened the hospitals are, the physicians and the workers working in these centers are. We're never going to have enough resources to build lots and lots and lots of clinics and hospitals. So how do we streamline the efficient utilization of these resources that we've already invested in? Digital tools can help here as well. Can we do more telemedicine? Can we really triage the high-risk patients from the community and bring them in at the right time? Can we utilize a lot of the predictive modeling to be able to say this patient is more likely to have an adverse event or a complication and be able to provide that targeted service before some of those things happen? Again, all those capabilities exist today. All of this data around population health, can we use that to forecast better? What is the healthcare infrastructure that's needed? Commodities that are needed? Instead of doing sort of blind planning, looking to the future, really use data to do that a lot more efficiently so that the resources go far. And that really goes to the final level from the governance standpoint and policy standpoint, is where we start to use all of this information to truly design a comprehensive health system that's driven by data at all levels across the ones that we just talked about, from patient to community to the healthcare delivery to the policy and governance level. And really what gets me really excited about all of this is the power of all of these new tools that are coming. I'm sure a lot of you, most of you, have heard about just the incredible capacity and capability that all of these machine learning and artificial intelligence tools are bringing to the table now. ChatGPT was only launched about 8 months ago, and already people have developed capabilities where these intelligent systems, I think we're revisiting the definition of intelligence, but these systems can literally listen to a conversation between a physician and a patient and synthesize all of that information to come up with a basic diagnosis and put that in. That's an incredible aid for an overworked doctor or medical officer or community health worker who cannot possibly know all of the world's information at their fingertips. These tools can bring that, and you don't even have to sit there and type it all in. So maybe what I would say in summary really is that this is just the beginning of the technology revolution. What we need to do to really make this a reality, to bring universal healthcare and access to all of the patients in a cost-effective way, is partnership. Nobody can do this alone. There's a lot of innovation happening in a lot of different pockets. How do we bring that together and work with the administration and the partners across all of the sectors to think about how do we do two things in parallel? One, truly innovate. The amazing thing about the Devolve system is that we have all of these laboratories that we can really customize these solutions to work in the local context. But then at the same time, also think about how do we do this in a way that's scalable and replicable and something that can be future ready, so that what we don't end up with is a bunch of fragmented solutions that don't talk to each other and that don't help us capitalize on the power of that transformational change. I'll just close with this, that, people always say it's hard to do big things that transform. That opportunity is in front of us. It usually takes a small group of people to make big things happen when you've got the vision. So my call to action and request for everyone for this session is, let's do it. It requires commitment, it requires vision, it requires leadership. The technology is all here. It just requires a small group of committed, focused, dedicated people to come together and make it happen. So thank you very much.
Thank you so much, Ruchika, for those insightful sentiments and perspectives. I think, how many of you, by show of hands, knew that the first mobile phones were 2 kgs? By show of hands. Only one person. Wow, good. I think there's something that Ruchika has said that really rings to mind, especially in my duty as the co-chair for ZMCC. She said, it takes a small group of people to make a change. And if you thought you were small to make a change, think about the mosquito. How many changes has it done to our lives? A lot. So thank you so much for those perspectives, Ruchika. We really do appreciate them. Up next, I'd like to call upon Dr. Kwasi Bohane, the Director Health Systems at Farm Access, and Mr. Eric Angula, the Head of Strategic Partnerships and Government Affairs Africa at Medtronic's Lab, for a presentation further enhancing and speaking about leveraging digital health for universal health coverage. Over to you. Please cue the presentation for us.
Yeah, as we wait for the presentation, I want to start by standing on existing protocol. Thanks for the organizers for inviting me. We're going to do the presentation together, and I understood we have 10 minutes. Yes, is it here? Oh, anyway. My name is Kwesi Boahene. I'm Director for Health Systems at PharmAccess. PharmAccess is an organization committed to using technology and data to improve the financing and delivery of care. So the main focus there is how can we ensure that healthcare can be financed and delivered on a sustainable basis. So we're not just talking about today that we deliver care, but tomorrow, the next day, and the day after. I'm from Ghana, and Kenya and Ghana have good relations. So for the sake of time, I might not be a bit diplomatic, but I think it's also part of why the organizers invited me to share some lessons based on the work that we have done. So if I relate the lessons that I've learned across the countries where we work and look at the system in Kenya, what I can say is that the healthcare challenge in Kenya is not due to lack of money and capacity, but is due to the necessity to implement strategy on a consistent basis. You know, some of the countries where I'm going to talk about to you, do we have something to flip? Oh, okay. Some of the countries that I'm going to talk to you about are sort of countries which in some extent copied from Kenya. You know, Kenya started this health insurance system in 1967. Ghana started its health insurance in 2003. But if you compare the two, you see that Ghana has made some remarkable progress. So these are some statistics. If I can get the next slide, also for the sake of time, you can get these slides from the organizers, but you can also reach out to me and I will share the presentation. I think we've heard the story from Medtronic about the importance of technology, so I won't go into that. Just to let you know that mobile payments constitute about 10% of the GDP of African countries. It's about 2% in Europe and the US. So you see that Africa is way ahead. And the question, which of course at PharmAccess we are very much interested in, is how can we use mobile technology to transform healthcare in the same way that mobile technology has been able to transform or lead to financial inclusion. Yes, please, the next one. So this is what we do. Like I said, we are leveraging technology and data to do that. We work with both government and private sector. Yesterday, Dr. Ganda presented the work that we're doing with Kisumu County. In Kenya, we have some fantastic private sector entities, including KPay and Safaricom. And we've been able to do all these things through the general support of the Dutch Ministry of Foreign Affairs, and I think they are in the room. So it's very important to have partners that are willing to go with you in order to take the risks. The next slide. These are some of the results that we have achieved. Once again, for the sake of time, I won't go into that, but you can, as you can see, one of the things that I feel proud about is that through our safe care methodology, so we've been able to support facilities, healthcare facilities, and across Africa, we've been able to reach over 7,000 clinics, and every month, these clinics are able to serve over 8.2 million patients. I think that's incredible. The last slide, and I think this is actually the point. The point here is that the first important lesson is the need to pool funding. So if you talk about pooling funding, underlying it is the need for government to commit funding to healthcare. The story in Ghana is that when they started the insurance, they set up a special levy, health insurance levy, and 2.5% of all VAT in Ghana, it goes into funding insurance. Compare Ghana to Kenya. Ghana is not richer than Kenya, but Ghana has been able to reach 62% of its population with insurance, and the statistics in Kenya is 28. So it's about pooling and using the funding that we have strategically. And the next one, and I think that's also what the panel is about, how do you use technology in the most effective way? When we talk about technology, most organizations and people, they talk about the delivery side, which is important, but there's also the financing side. And I think it's important that we look at how we can use technology to mobilize funding and to ensure efficiency in the use of funding. And these are examples where, if I would just use one of them, Lagos State, they have insurance program, and they've tied, because they are using technology, they are able to see the outcomes of each facility. And they've tied the financing or the payments to the facilities to their quality performance. And I think that's the best way of ensuring efficiency in the system. And the last one on that side is private sector participation. That is key. So once again, the lesson from Ghana, there's a good collaboration between the private sector and the government, to such an extent that a group of the private sector body, they have only 7% of the healthcare facilities in the country, but they deliver 30% of the healthcare. The government doesn't bash them on that. The government is proud that they are leveraging innovations from the private sector side to do that. And this is the last slide, and I hand over to Metronics. It's good that we have vertical programs. We have HIV/AIDS because we need to target it efficiently and effectively. It's good that we have mother and child care because it's a pressing need for that. It's good that we have programs on TB and etc. But at the end of the day, when we talk about UAC, we're talking about an individual which has all these conditions. And technology can help us to pool all this funding together to ensure that the pregnant woman who may have HIV and may suffer from TB or whatever will be able to get the support in a consistent manner. UAC means bringing all the funding together for the benefit of one person, and technology help us make that possible. And lastly, I've heard, I've been here for about 3 days, and I've heard some countries saying they are small, others saying they are big. There's a proverb in Ghana which says that, for those who says they are small, there's a proverb in Ghana which says that you can only complain about your size if you have never spent a night with the mosquito. Yeah, you know how the mosquito can cause havoc. And those who think they are big and cannot organize, we also say that the buffalo does not complain about the size of its horns. It just moves. So with that, I'll leave you, and then nice for inviting me to be here. Thank you very much.
Thank you so much, Dr. Kwesi. I think this afternoon I'm the most privileged because my governor has just spoken ahead of me, and I don't know how many people have heard their governor speak ahead of them in this forum. If there's any joy today, that is my joy. My role actually in this breakaway session is really to bring all the discussions that have come ahead closer home. And we've had a very nice video showing technologies that are actually being implemented currently in this country. These technologies are not far-fetched. These technologies are actually currently impacting patients, impacting populations across the country. My role today is also to remind us about the UHC, to remind us about the position where the government has really and is really investing to ensure that we use primary healthcare as an avenue towards UHC, but really specifically speaking about primary care networks. And I want to address the role of technology in being able to address that critical aspect. So maybe some slides. I'll not talk to all the slides, but just talk to two key slides. One, just on UHC, the priorities, and to remind us. So UHC, we all know the definitions, but the four most important things that is going to help us to achieve that is one, to think about the human resources for health. The second bit of that is health financing, which I'm happy that my colleague, Dr. Kwesi, has spoken about. Then we have the role of technology, be able to support those UHC endeavors. And then, of course, lastly is the health commodities. And within health commodities, there's the opportunity for quantification and forecasting and ensuring that the commodities are available. Now, in that regard, I want to pose a provocative question. The government has invested about 100,000 community health promoters. The government is buying devices and gadgets, phones, kits for community health promoters. And the expectation is that the community health promoters are going to be screening at community level and referring those with chronic diseases or those with elevated readings or conditions into the primary care networks. We all know the structure of the primary care networks in terms of hubs and spokes. Now, that means that significantly we are going to see an increased demand in terms of patient numbers. We all know the status of our primary healthcare, and we all know the needs in terms of those four items I've mentioned: human resources, health commodities, financing, and technology, even at those lower levels. So I pose this question then to counties and partners and stakeholders who are here today. What are we going to do about those increased numbers at primary care network level? The solution is simple. We have an opportunity, a unique opportunity now to leverage on technology for downward and backward referral. And I want to talk about one of the technologies that have been shared, specifically the SPICE model of care. So let me just say that Medtronic Labs is a system innovator that really looks into addressing the gaps around care at primary care level, but really most importantly, focusing on patient outcomes at that particular level. Now, when we think about the CHPs referring patients upwards into the spokes, eventually into the hub, what will add value and increase efficiency in terms of utilization of resources will be if we could leverage on technology to be able to reverse and backward refer those patients into the community and back into the spokes. So we present an open source platform which is called SPICE, as I mentioned, that has the uniqueness to be able to connect and integrate all those spokes and the hub in a way then that we have an opportunity to longitudinally manage those patients, whether they go upwards into the hub, whether they go back into the community or into the spokes, but most importantly, in a risk stratified manner. So we are talking about community health, we are talking about primary care networks, and we are talking about chronic diseases. But it doesn't end there. How do we then provide specific insights around data that can support the utilization of community health promoters in a way then that is data-driven and outcome focused? So then again, the opportunity to utilize technology for us to start to look at what are the gaps and opportunities to improve the decision support at that particular level. I commend the government for taking that step, but we have a technology that has been able to provide specific benefits in terms of primary care network management of patients. One that is really, really important is to be able to drive personalized patient management plans, but also most importantly, to be able to provide the opportunity for the community health promoters to actually do the work for which they were intended to do. Lastly, the government has made a lot of effort. And I know in our minds in this room, we are thinking, what is happening to all these solutions that have been discussed here today? But I must say that the government has moved really quickly to ensure that all these solutions speak to each other and that there is opportunity to integrate the services so that the same patient who is a mother and has diabetes and hypertension can be seen appropriately without stifling innovation. Thank you so much.
Thank you so much, Dr. Kwasi and Eric, for those insights and perspectives. It's really fascinating to learn what countries can learn from each other. For me, it was mind-blowing to learn that in terms of financial insurance, Ghana is at 68%, and Kenya is learning from that. And just as rightfully Eric did mention that there are lots of steps being taken, there is progress, and as we always say, a journey of 1,000 miles starts with one step. Now, I know we have very generous people in Africa. Someone left me their phone. Thank you so much. It's a gift from Ghana. Thank you. I'm just joking. You can come pick it up. Without further ado, we had promised you a very distinguished panel, a set of panelists who will be sharing crucial insights into this really fascinating topic of the intersection of health and technology and what we can do to achieve universal health coverage. So you have their amazing bios in the booklet, and in the interest of time, I'm not going to read their bios. I will kindly ask them to come to the stage when I call out their names, and we will begin with our Excellency, the Governor Wanga, who's the session chair. We will have Dr. Martin Sirengo, who's representing the Permanent Secretary, State Department of Public Health and Professional Standards in the Ministry of Health, Ms. Rita Okutha, the Executive Board Chair at Campe, Kenya, MTIBA, Ms. Caroline Bindio, the CEO, Amref Health Innovations, Mr. David, I thought it was a gift. He's taken back his gift. Thank you. Dr. Susan Ontiri, the Country Director at the International Center for Reproductive Health, Ms. Harriet Kongiri, the Policy and Strategy Advisor at UNAIDS, and last but not least, and certainly not the least, Mr. Brian Redman, PEPFAR Coordinator, Kenya, and Mr. David Munyendo. Is David here? Oh, yeah. Mr. David Munyendo, the CEO, Christian Blind Mission. Thank you so much for joining us on stage. Let's give them a round of applause as we settle in. Thank you. Thank you once again. Hello? Okay. Hello, hello? The mics have jammed on me. Hello? Yes, this one is working. Sometimes technology fails us, but we have to make do. And I will start with our session chair, Your Excellency, Governor Wanga. You had a really powerful opening statement around the impact of health, the progress that has been there over the past 10 years, the milestones, the challenges, the learning lessons, the opportunities that have presented themselves. And even from the video, we've seen the critical role that communities play in this whole ecosystem of achieving universal health coverage. The counties, we know there is implementation of the community scorecard, which helps in hearing the voices of the communities. From your perspective, how best can counties scale up these participatory approaches on digital transformation to transform health outcomes?
Thank you very much, Liz. I was hoping to hear the other voices since I had already made some remarks, but thank you for that question. And let me recognize in the audience here my CC for Health, Roslyn Omolo. Roslyn, in case the questions are too hard, I will ask you to help. But I think Homa Bay has put a lot of premium on public participation, and as the same for all other counties, because it's a constitutional principle which anchors our new constitution and also devolution. It's about hearing the voices of the people at the grassroots and acting on that basis. As far as digitization is concerned, and as far as use of technology and provision of health services and also just catalyzing, I saw on the video there a telemedicine scene. And that telemedicine scene, if I'm not wrong, is in Sindo, in Homa Bay County, where we have a partnership with Gertrude's Children's Hospital, which is a premier children's hospital. And, Sindo is on the beaches of Lake Victoria in the rural areas. And now, parents can come with their children with complications, who have a high, and they can sit there and talk to specialists, in Nairobi and, be advised. And that saves on the distances, saves on the cost, saves on specialization. And I just wanted to, put that out there. And then to speak to how we are, putting digitalization at the center. After listening to the voices of the people and after, hearing them out, the one thing I think we should focus on is looking at where are we at. What is our baseline as far as digitalization is concerned? What are we getting right? What are we getting wrong? Where are we at this very moment? Because for us to progress, we must know where we are coming from. And then how do we open up this space to private sector? Because really, we can try as governments, but really the gurus of digitalization private sector people. Government, we try, and even we are trying, even right now we are trying to develop a government-based system for managing our health system, but we are not moving as quickly as it would be if we were, in partnership with the private sector. And then there's a whole area of regulation. In my opening statement, I spoke to issues of confidentiality. How do we handle the data? Patients are concerned, people are concerned about their information. Where is it held? Who's holding it? When can they use it? Where and when can they use it? So I think that's also a very big concern around the public that we must take care of with regulation. But also when we are regulating, I think we must take care not to over-regulate, because you can also try to regulate to a point where you now stifle progress and growth. So I think that's another key area that we are looking at. Our presenters from Farm Access, have spoken to the issues of interoperability of systems. So today, Sirengo will come with a system. It's a useful system. It handles for you one part. Then Rita also comes with another system. It's also useful, handling something. Now, you want both, but they can't talk to each other. And I think that's, I saw in Farm Access's presentation, that I think government is putting a lot of premium on interoperability so that we can take both systems, take the best of Sirengos and the best of Ritas, and if Liz has another one, and put them together and they speak to each other and we meet the objectives. And then there's, sustainability. Governments are, we are here only for a season. I'm here today, I might bring a very, very good, wonderful system, and Liz maybe supplied me with that system. Then tomorrow, somebody else comes. And then they say, no. This one just looks like Wanga, walks like Wanga, talks like Wanga, wedding like Wanga. I don't want anything that looks like Wanga around here, out. However good, then people go back to square zero, and then they want to start afresh. So anyway, as we look at community participation, and some of the concerns that arise around digitalization are what I have highlighted, and maybe I will come back a little more to speak a little more.
Thank you so much for those perspectives. I really love the fact that you mention and acknowledge sometimes we learn from each other, and how do all these fascinating and helpful and efficient innovations talk to each other so that they can complement and not compete with each other. We've heard from the county's perspective, from the Ministry of Health, Dr. Sirengo. What is the ministry doing in terms of embracing the power of digitalization to fast-track universal health coverage?
Thank you, Liz, my classmate. My name is Dr. Martin Sirengo from the Ministry of Health. I'm the Director of Health Sector Coordination and Intergovernmental Affairs. I'm sitting in here for PS, Ms. Mary Mudhoni Muriuki, PS, State Department of Public Health and Professional Standards. She's been around. She really wanted to take part in this discussion, but because of some delays, she's rushed to the airport to go back to Nairobi to attend to other businesses. So thank you very much for the question. Before I respond to the question, I think it's in order for me to recognize that there's a lot of work that has gone into the space of digitalization. As we've seen from the previous speakers, as we've seen from the video that was projected here before we started. Now, this digitization is not entirely a new concept. We have been through this journey from way back. As you recall, in the past, a lot of health systems were manual, paper-based, using the old files, as it were. But the Ministry of Health is working alongside the recommendation of WHO, which is investing in the health information management systems, which supports the digitization process. Of course, the new hype about digitization came with now the new government, that we must digitize our systems. As you saw from the presentation and the previous speakers, there is a lot that has happened in the space of digitization in the health sector. Right from the service delivery points of care, where we have electronic medical systems taking care of patients, to issues of, digital systems for evaluating diagnosis, like imaging, for instance, and that together with telemedicine, where a patient in the rural area can have the benefit of a specialist sitting in Nairobi, looking at their story and their results from the laboratory or X-ray to assist in the diagnosis. And of course, all that has to be fed into a system that we call the Kenya Health Information System right now, which goes all the way to the national platform. And this system is so robust that all the public health systems and most of the faith-based organizations are actually linked to it, with a few private health facilities. And at the national level, we're able to tell at a click of a button what kind of services are available where and to what level. The same is available online through the Kenya master list. If you want to know how many facilities Honorable Wanga has in Homa Bay, you can just click and see that. But digitization does not stop there. We have embraced digitization to address other things, like logistics management. For commodity management and supply chain, we have digitization in the space of management of human resources, an example being the Integrated Health Information Management System, where the Ministry of Health currently is developing a system where all healthcare workers in the national government and in the county in future will have their data in that system. And you can click and say which county has how many specialists, has medical officers, nurses, and so on. So at the national level, when we look at digitization and where we should be, it is a system where we would like to use it to improve efficiency in terms of planning, in terms of budgeting, in terms of accountability, because at a click of a button, you can tell what is going on where, including financial management. Towards digitization and working with the counties, I think some 5 years ago, the ministry embarked on a process of UHC, of course, during the pilot, and a number of things happened, including connectivity to fiber optic network, beginning with the county referral health facilities across the country. And going forward, we will wish that even at the lowest level, dispensaries, health centers are connected to this system, which we call the digital superhighway. Okay? Of course, the challenge will be there are so many different things happening in this space, in different counties, with different partners. You may find every disease entity in this country has almost exclusively its own system. HIV have their own, TB have their own, which they call TB, reproductive health have their own, and so on. KEMSA have their own as well, which they use for logistics management. So the question at the national government right now, and for us to move towards the use of digital superhighway, is how to speak to each other so that for the indicators that I wish to export from this system, I get. The indicators that an implementing partner working in Mombasa would like to have can also get. So what are we doing? Two things. That's basically to put standards in place and regulations. The ministry is working on a digital health bill that will put in place standards of how the digitalization in the health sector can happen in terms of what is the minimum that is required by each one. That will also define the different access rights for the different entities and make it interoperable so that whatever system exists in which corner can be able to tap in. And whoever wants to export any kind of information based on their level of access can actually get that. Number two, the ministry is working on the guidelines, what we call the governance guidelines now, that will actually spell out the regulations and the expectations of what we need to be able to plug into this. So in conclusion, what we look forward to is to request all our partners and the counties to work with us to make sure that all your needs are taken care of, don't be left behind. So as we move towards this, everyone's digital needs can be met. Thank you.
Thank you so much for sharing those perspectives and the brilliant work that's going on at the ministry level. You know, Daktari here, because we were classmates during our master's class, preempted my second question, which was around the digital superhighway. So thank you for sharing those perspectives. We'll switch gears a little bit to innovation. And I will come to you, Rita Okuthe. As an innovator, how, we've heard about MTIBA, the fascinating work that is going on there. How is it being implemented, and what are some of the experiences you can share with us as an innovator on how MTIBA is impacting healthcare at the county level?
Thank you so much. So I will speak about MTIBA in 3 areas. We're also known as CarePay, but the customer-facing name is MTIBA. So first of all, I've had a lot being talked about the basics. I just want to confirm that Kenya is leaps ahead in terms of technology, and especially the use of the mobile phone. So if you think that you have about, on average, 52 million customers who are connected to the mobile phone, and 30 million active M-Pesa users per month, it tells you something. It tells you that we are ready to take that digital leap. And the first thing that MTIBA does is takes away, the cards that you have that sometimes you present. We put that into your mobile network. So it's very personalized. You can go in there, see what your medical insurance benefits are, how much you've used, what the balance is. Now, when we worked with the UHC in specifically Kisumu, we were able to really deliver this. And, it was a huge, huge motivation for the end user to really be clear on, what exactly has happened and how much have I spent and which hospital have I gone to. Now, I think the consumer side is probably not as difficult as upstream. There is creating the demand, that's fine. But I think on the supply side, that's where I think that ourselves and other innovators can really support county governments. So let's start off with, just transparency. I walk into a hospital, I'm diagnosed with malaria. The treatment should be fairly standard. An anaphylactic, maybe a drip, depending on how badly off you are. The pricing also should be fairly standard. But however, if this is not digitalized, because you see, the one thing that technology drives is transparency, accessibility, and technology bridges distance. If this is not clear, then different patients have different experiences in different hospitals. So MTIBA also has a solution that helps in administration of claims. And this is very, very useful from a county perspective in really understanding, the drugs that you order from KEMSA, how are they used, where they've been used, what are they being used for? And as people walk into hospitals, into your level 2 and level 3 hospitals, you can even predict if you're likely to have a pandemic or a crisis. So if you usually have 2 people walking in for malaria every day, and then you suddenly see 50 people, 60 people, okay, there's a problem with malaria. And you can proactively react. Because what happens is, we declare a pandemic and then there's a knee-jerk reaction and everybody's flooding in, focusing on this and forgetting other things. The second thing that does is that it decongests your referral hospitals. And I'm sure from the ministry, you know this. The referral hospitals, if you go to the casualty department, it's really filled with people who can be treated at level 2 and level 3 hospitals. It's really malaria, TB. It's very basic treatment that can be done at level 2 and 3, and therefore decongest level 4, 5, and 6 to really focus on diseases that are really critical and require specialist care. The other thing that I would say is empowering the community health volunteers. That is really the crux of where our public health system lies. These are the people who go around, who know exactly what is going on. Finally, the last thing that I would say in my experience, I think is very close to what Her Excellency has referred to here. Continuity beyond tenures of individuals. I think health is a right to everybody. It's not a privilege. And therefore, if we are going to get into digitization and begin a digitization program, to get the best out of it, it has to be sustainable. It has to be something that supersedes individuals. And that will help also with the donor community. The donor community invests a lot into health, but it's still a bit fragmented because, for some reason, when we started investment in health, we were looking at, disease lines. So I think somebody spoke about that earlier. You have HIV, then you have tuberculosis, then you have pregnancy. And you never imagined that, this one person could have all three. And then if you go into your database, you probably have this one person listed 3 times, the donor is probably spending 3 times more, and the lack of transparency. Once you build a system that is transparent, such as MTIBA has, where you can see who has walked into a clinic, what have they been diagnosed with, what have they been treated for, how much has it cost, that transparency encourages donors as well as the public sector to invest and fund more. So that has been our experience. Counties are at different levels of digitization. Some embrace it open-heartedly. Some are a bit more cautious. And some perhaps do not see it as an immediate priority. Yeah, they see healthcare as a priority, but digitization of healthcare may not be a priority. I think one of the things that you can perhaps do for us, Madam Vice Chair, is just to make sure that from a county perspective, the governors understand the importance of digitization and how it saves them money and provides a better and more consistent experience. There are more exciting things that can happen with technology. You can have a simple mobile clinic. I've had a lot being talked about telemedicine here, but how do you make it come alive in a way that actually helps, the bottom end or the final end or the citizen living in the farthest part of Kenya? There are mobile clinics that now you can have a 3G device, you can connect and speak to a specialist. Why don't we take them out on market days? On market days, we know that, everybody in the community comes out. Take it out on a market day with your community health volunteer, call in the specialist, and then the upward and downward referral that we've been talking about here can then happen. In the absence of that, people still have to travel long distances to reach the nearest health facility, and you actually don't make the difference. So, in summary, what am I saying? Technology bridges distance. Technology breeds transparency. Technology is also a great equalizer. It means that the access that I have to a specialist, say in Nairobi, is the same access that somebody potentially could have in the farthest part of Kenya with technology. So with MTIBA, that has been our experience. I've taken it, a little bit higher and not gotten down into the details because I think it's important we take away and we have clear resolutions as to how technology can really accelerate access to healthcare. Access is a real thing and consistency in that access. Thank you.
Wow, thank you. Thank you so much. Technology bridges distance. Technology is a great equalizer, and technology upholds transparency. And I think one thing, just based out of the threads that you've shared, it also helps us with the predictability so that we are able to monitor the emerging trends in different localities. Thank you so much for that. Caroline, I'll come to you because part of the 3 things that the chair of the session has talked about, Dr. Sirengo here has talked about, Ruth has mentioned, technology is as good as the data you feed it. And it's very interesting, Chair was talking about the security of data. Who owns this data? How do they share it? Where is it stored? Just thinking about yesterday, I got a call from a landline that said, is this your number? They spelled out my number. They gave my full names, my ID number, and I felt, oh, this is a scam. And so before we went further, I just hung up. I can imagine how I felt with just my name, my ID, and my phone number. I can only imagine if somebody's data, health data, gets into the wrong hands. So in your perspective and in the work that you do around data sensitivities in innovation, just shed more light to us on how do innovators safeguard health data from unauthorized access?
That's a very good question. Thank you, Liz. And I think everything that has been said here suggests that there'll be more digitization, there'll be more digitalization. With interoperability, there'll be more consolidation of data So when you look at my data as an individual, you'll be able to see my gender, my age, where I live, what is my level of education. You know, you'll be able to access a lot of data about me. And when I think about safeguarding data and the question that you've asked, I mean, it's really in three parts. What is unauthorized access? What is health data? And who are innovators? So when I think about unauthorized access, I'll just give you a very brief story of something, a true story of something that is happening now as we speak. There is a software called Move It, and there's a mass hack happening as we speak today, and that hack started in May of this year. And since May, they have managed to penetrate 600 plus organizations across multiple countries. They have hacked governments, financial institutions, airlines, you name it. And just this week, they were able to steal 4.5 million records, health records, from the state of Colorado. Imagine that, yeah? And we are still not yet able to identify how we are going to stop this. So this is clearly an intentional and malicious data breach. But not all data breaches are intentional or malicious, but regardless of intent, they all have the possibility of bringing risk to the patient. So when we now think about, we move from the unauthorized access to health data, what is health data? And I think this question is becoming more and more ambiguous, more complicated, the more we digitize. So now, right now, we have different ways of collecting data. There is voluntary data. We've seen here how community health promoters are going door to door, collecting data from households. And this is, in many cases, voluntary because they are required. They are requested to give their consent, and they may choose to or not to. And then we have more, something that feels more coercive. During COVID, there were some very temporary measures that were put in place to allow organizations like airlines, hotels, conferencing facilities to require us to provide them with our health data for us to be able to access certain types of services. Now the pandemic is, it has been scaled down, and that data has outlived the pandemic. Where is that data? Is that data defined as health data? Who is safeguarding that data? And of course, there is the inadvertent data that is collected. Many of the apps that each of us use is collecting data about us. And part of that data that it's collecting is our location data, our GPS data. And that location data can say certain things about me. It can tell you, for example, that I frequently go to a rehab center. Is that health data? Is that data safeguarded by anyone? So as we think about what is really health data and how do we define it? I think right now there are very provocative conversations going on when you think about the possibilities of machine learning, artificial intelligence, when we look at intersectionality and the determinants of health, that something like, my level of education, where I live, my employment status, my socioeconomic status, my gender, where I access my water, all of those things are part of what determines the status of my health. So when you look at it that way, the question really begs, is all data health data? And how do we ensure that we are protecting that data? Because the risks associated with exposure are massive. When we think of innovation and innovators, I think, many of us, myself included, when I think innovation, the first picture that comes into my mind is a startup with young people doing something digital. But actually, innovators come from everywhere. They may be coming from the medical sector and innovating for health, but they could be coming from many different sectors, building some of these solutions that we've seen here. They could be from the public sector, ministries of health, governments, innovating and creating solutions for some of these challenges that we are facing. It could be private sector, whether startup or established organizations like Safaricom. It could be local innovators. It could be somebody from the region within Africa. It could be somebody from San Francisco, Colorado, Ghana. It could be anywhere. So essentially, we're saying an innovator is anybody from anywhere. So if you think about it, anybody from anywhere can come in, create the solutions that are collecting data, and they are storing that data. So when we think about it that way, the risks are massive. And I think it is clear that it is not about just the innovator safeguarding that data. It is about the ecosystem. How do I collect that data? What tools do I use? And what safeguards are within those tools? Which individuals are we asking to collect that data? When you talk, whether we're talking about the community health promoters, doctors in health facilities, whoever it is that we're talking about, do they understand what it means? Are we providing them with the training and the knowledge and the equipment to safeguard that data? How is that data moved from one place to the other? This massive hack that is happening right now, it is because of the software that is being used to move data from one place to the other. It is not the data that is the tool that is collecting the data or where the data is stored. It is that movement. So how do we move data from one place to the other? And when we think about interoperability and the consolidation of data, and even just the how data it's very easy to move data from one machine to another, from one jurisdiction to another. What are the rules, the policies, the regulations around that? How do I share data? For example, if I'm a project, I'm collecting data in your county governor, and then I want to send that data to you. Are there certain protocols? Do I send it as an attachment on email? Do I put it on a flash disk and send it to you? Is there a protocol that I can send data digitally from my machine to your machine safely? And where will it be stored? So thinking of all these things is absolutely an ecosystem challenge that we need to solve as the ecosystem. Thinking about laws, regulations, the national law here in Kenya, the Data Protection Act, but also thinking of global requirements like the Human Rights Act, thinking of health data jurisprudence, and there's a lot of that has happened in the HIV space in Kenya, and understanding that it's complex, that we need to understand and know, and we need to be agile and change as the ecosystem is changing. What health data means is changing, and what technology can do is changing. So it's something that we have to work on together.
Thank you so much, Caroline, for those perspectives. And you've kind of answered or shed more light on Rita's question on, why some people are a bit hesitant or cautious around digitization. But like you're saying, it has to be a collective action. People have to talk to each other and work together to be able to overcome this, such startling revelations of such a hack. 4.5 million health records without knowing where they are can be really troubling, but it has to be developed in collegiance with the rest of the ecosystem. Thank you so much for those perspectives. One of the things I really want to shout out Katra and the rest of the team that really put this panel together just because of the inclusiveness. And I mention this because during the pandemic, I feel there was a lot of, when we began doing a lot of information, education, communication materials, there's one group of people that was left out, which was persons who are differently abled. And they often are left out in different conversations. And I think it was AMREF who was one of the first organizations to have the IEC materials on protection against COVID-19 in Braille. So it's really fascinating and amazing to know that Katra, this was considered during this panel, and to bring in Mr. David Munyendo to shed perspectives on how can digitization be used to improve inclusion and access to health services for special groups such as young people, people living with HIV, people with disabilities, and even people who are often left out, women. When we talk about digitization, there's a huge gender gap as well. Over to you.
Thank you so much. I want first to agree with my speakers went first by saying that inclusive digital solutions actually promotes equity in access to healthcare. And also it promotes visibility of those who tend to be left behind. Because in many cases, we assume that our community is homogeneous, but in reality, it's very heterogeneous, and every sector of the population have their own needs, and they utilize the health services differently. The most irony about this is that the most people with unmet needs are the most at risk to be excluded from even the mainstream services. And by this I mean that we have persons with disabilities, persons with HIV, women, youth, among other vulnerable groups. I'm using the language of person first, because many times when you look at a person walking into a health facility, we always feel they are sick or they are patients. And many times they may not be sick or they may not be patients, but they are just clients of the healthcare system. So the more you convince them that health is an investment and not an expense, you get it right, because they see their role more meaningfully and they walk in even at times with a solution, are not entirely coming because they are at the mercy of the healthcare system. Now, allow me to say that the challenges many times we have is the issues of disaggregated data, because we tend to focus on the disease, we tend to focus on the impairment or disability, and forget about the person. But the more we aggregate data, we realize that we need to go an extra mile to ensure nobody is left behind. I'm saying this because even in the aspect of digital solutions, issues of participation is very important. And participation is a key pillar of empowering community to drive their own destiny in terms of healthcare. And the more you give them choices around the healthcare, the better, instead of getting fixed and prescribing what needs to be done. For persons who are more marginalized, it's always good, for example, if I can pick on persons with disabilities, to ensure that they own and they lead from the front line. And I've listened, I've watched the video. There are several apps that are being developed. Some have been developed, but at times we forget about accessibility. How do we ensure that everyone can use and benefit from available digital solutions? For example, if a person has visual impairment, how do you ensure that the digital tool has talking software or is able to voice? And if the person who is using a smartphone or even just a normal phone, how do you ensure that this person can equally have access to different opportunities using the same? Because the challenge we have is that we are so fragmented, and you have to keep on shifting from one app to the other to benefit from the vertical program that we have. Also, you'll find that using of the mobile phone app gives a lot of opportunities to the individuals. And I want to pick one app which we are currently using in 7 counties. That's Vihiga, Bomet, Kiambu, Kajiado, Embu, Meru, Kwale, to screen eye health. It's called PIC. So in terms of empowering the community, we have trained community health promoters as frontline soldiers, and they screen from house to house. So instead of carrying the snail and chat, they only have the phone. And this data is relayed real time to the dashboard. And so the health workers know how many people in a given geography are in need of eye health services. Those who require surgery, those who just require the medicines, those who require the spectacles, and it becomes so easy to either transport the patients or the clients, in this terminology, to the point of service delivery, or to have reverse referral, whereby you take a team to the community to ensure that you also reduce the cost and time to be incurred by the community in terms of accessing the services. I also want to speak to the issue of digital solutions actually empower individuals to lead what we call independent life. By this I mean that when you send a reminder, somebody doesn't have to depend on an assistant to be reminded when to go back for the appointment. When you send a reminder or when to take or to refill the drugs, somebody doesn't have to depend on a family member. So it promotes independent living, and empowers the individual to ensure that they're able equally to play their role in healthcare. The other challenge you normally have, you may have a very good digital system, but the health facilities are not accessible. And for example, if I was coming there on a wheelchair, it becomes really challenging. Even if it's a modern wheelchair, the one that's automated, it becomes very challenging. So as much as we think about the system, let's think about it holistically, from the infrastructure to the digital solutions, to the people and equipment and all that. I'm saying this because practically we did an assessment of about 38 health facilities, and the biggest challenge was not even about digital solutions, it was more into physical accessibility. So we need to combine both in order to deliver better, attainable standards of healthcare for the community and for everyone.
Thank you so much, David. And I think David has left us with a challenge, and it's a challenge to all of us as innovators, as ministries of health, as county leaders. How can we ensure that we are more inclusive and think holistically about the solutions that we offer? Dr. Susan, coming to you. As the SDG lead on the SDG Kenya Forum, what opportunities exist for counties to leverage on technology and digitizing health service to enhance health service delivery, especially in the context of SDG?
Thank you. First of all, I need to appreciate that even as we are having this discussion on digitalization, we are having it in the framework where we have an enabling environment. The government has invested in a lot of policy guidelines and framework that allow these aspects of healthcare to really permit. We've seen efforts by the Ministry of Health, the Ministry of ICT coming together to collaborate. And if counties are to leverage on that, one of the things that my reflection is we need to move beyond pilot projects to scale. Take an instance or an example of what Dr. Sirengo mentioned. For over the last almost 10 years, we've had the electronic medical records, the EHIS, but it has only been rolled within the HIV programs. And also when you look at the coverage, it's only high-level facilities, hospitals, that are using it. At what point will a dispensary somewhere that is providing not just the HIV programs, but all the other programs are able to actually embrace EMR system? The whole aspect of interoperability, we have in several systems that are being implemented by the various partners. County governments, specifically the county development, the county departments of health, provide the leadership and oversight. They are an integral element in terms of coordinating all efforts that play or different implementing partners come on the ground and ensure that all these innovations are well coordinated and there is oversight and there is actually scale up. When you look on commodity supply chain system, when I reflect again on the program that we've implemented jointly with UNFPA with funding from FCDO, where we got KEMSA developing an integrated logistic management system for the family planning commodities. For the first time, we are going to have a system that allows even a healthcare provider at a dispensary to be able to see the commodity stock levels at KEMSA. The promoting end-to-end visibility ensures that there is improved efficiency when it comes to the supply chain system. It ensures that there is a rapid decision-making process, as opposed to currently what is happening where we are having the hard copies. We know we wait at the end of the month to submit to sub-county, county, and the same is aggregated. The opportunities for counties to see that is to also ensure that they support the rollout of these initiatives, because what we know is initiatives come to the county, there is a training, maybe a class of master or even select healthcare facilities, but it behooves the county department of health together with the partners to ensure that there is continued mentorship, that healthcare workers up to the dispensary level are able to actually utilize this system and continuously, and also investing in data quality checks. Because when you talk about now digitalization, it means that the data that is entered from the dispensary level, there might not be sufficient quality checks across the system to ensure that it's of high quality. The other thing also that taught us when you remember the COVID-19 pandemic, when most services were paralyzed, Think about all the innovative solutions we came up with, even including capacity building of healthcare workers. We embraced digital health systems to provide trainings of healthcare workers. Within our program for the performance monitoring and action, we were able to roll out massive trainings across the county, collect data using digital health platform. And when you take up such initiatives, then it means that there is also improved efficiencies. Because when you think about the number of trainings, for instance, that happen at the healthcare facility or within the counties, some of those trainings can actually be converted and we can embrace use of digital platforms. There have been several apps that have been provided so that we are having a system that provides continued support to the healthcare workers beyond the classroom training that is offered. Lastly, when I think also about the supportive supervision that happens, we go with the supportive supervision books, we write, we leave them, but within this era where we are having digitalization, converting some of those systems into an online, where if you are seated at the county, if you are CEC, you can basically drill down to a particular facility and see the last supportive supervision visit, what were the key findings, what were the action plans, and also follow up for continuity to see whether the same have been addressed. So I think the time is right. There's a lot of opportunities, there's a lot of goodwill, there's a lot of investments that are going from different, led by the government and also partners. So the county governments should be able to come to a place and ensure that there is coordination so that all these efforts are well utilized.
Thank you. Thank you so much, Dr. Susan, for emphasizing on the point of coordination. And I always refer to the Swahili saying that says, kidole kimoja hakivunji chawa. And you really reiterated it in terms of you all need to come together to be able to feed into each other to push those milestones. Ms. Harriet Kongin, you know, there's been a lot of great discussions and examples, and I've had HIV and AIDS being lauded as a good example of some of the data that has been used. In your perspectives, what are the existing opportunities for digital health innovations in Kenya that perhaps have been used by the UN, or what the UN is doing in this space that can be emulated?
Thank you very much, Liz, and just a lot of appreciation for everybody here for actually being here until this late. Just to say that, again, I would like to really congratulate both levels of government, both national and county government, for the efforts that you're making in terms of this whole discussion around digitalization and implementing, policies, ensuring that we are able to use this technology for development. Within the UN, we have a new cooperation framework that is signed between the Kenya government, or that rather the Kenya people and the UN. And one priority within that cooperation framework is the whole, it actually prioritizes digitalization as part of accelerating the SDG goals, the social development goals. The UN also has a joint program that brings together the different agencies within Kenya to basically address digitization, and it focuses on inclusive digital infrastructure and increased investment towards basically trying to bridge the digital divide. And one of the focus of this joint program is looking at partnering with the government, development partners, the private sector, civil society, and so forth, to really ensure that even as we talk digitalization, we focus on areas and particularly places that have been left behind, and ensuring that nobody is left behind, even as we talk and implement digitalization, and especially when it comes to health. Now, these specific areas that we are looking at are ASAL areas, that is arid and semi-arid lands and counties in Kenya. And we are also particularly focusing on informal urban settlements. We say this because these are the areas that have been proven to be really behind when it comes to issues of poverty, or rather issues of development. But again, when we come to HIV and AIDS, you'll find that data has shown us that these specific geographical areas are really lagging behind, and most of the people that live in these geographical areas, again, are at risk. Two things are happening. You realize that with regards to HIV and AIDS, the young population, that is the young people, and especially adolescents and young people, and more specifically girls and young women, are really at risk. And so what we are looking at is focusing on these populations and ensuring that even with the digital technology, these particular groups are not left behind, and that we come up with technology that really ensures that they are included. In terms of opportunities, we really see a lot of opportunities for partnership, and as I said, what the government is doing is really laudable, and these are really areas of opportunity to work with the government, both at the national level and at county level, to ensure then that there is space for everyone on the table in terms of digitization, and that we are able to really help and support government through various ways. And I see technical assistance and capacity building as one area that the UN and UNAIDS comes in, policy development and advocacy, funding and resource mobilization, data governance and standardization, research and innovation, and finally, perhaps just looking at partnership and knowledge sharing. What is happening across different counties, what is happening even within the region and globally, and bringing that knowledge back home to basically see how we can leverage what is happening success stories from other regions and globally. So let me stop there because of time and really take it back to you. Thank you.
Thank you. Thank you so much, Harriet, for bringing in the perspectives of the arid and semi-arid counties, the ASOL areas. And I could see Dr. Sirengo here taking notes on the open invitation for exchange of learning that I think Dr. Susan also did mention about coaching and mentorship. And the UN has so gladly offered, the technical assistance, the advocacy, the quality assurance, as well as some insights into R&D. Thank you for that. Last, but certainly not the least, Brian, Kenya has collaborated with PEPFAR for nearly 2 decades, actually over 2 decades. How has PEPFAR supported Kenya's health system to digitalize, and what are some of the recommendations you have for Kenya in terms of optimizing everything that has been mentioned?
Great, thank you. And let me just say it's difficult to be on the back end of such an esteemed panel. And so I want to thank you all. And a lot of what you've said I had planned for, so I may just throw this away. As you mentioned, PEPFAR has been active in Kenya for 20 years. We're happy to be here. And I have to say, PEPFAR has really evolved over those 20 years to really respond to the epidemic. And we've done that through data and really understanding what the epidemic looks like and how to respond to that and really get to the point where we're now at epidemic control, or close to it. We're really close. Now we need to continue to look at that to identify where we can find those outliers who have not yet come in for testing, who have not yet gotten onto treatment, and who have not yet gotten virally suppressed. But and we've really moved a long way from the paper-based systems that we started with to now something that people have on their phone and understand what their health looks like. And so I'm really excited to be here in Kenya to identify some of these new pathways and really, actually, I think probably go beyond some of what we see for health even in the developed world. So I think we've got some great opportunities here that I'm looking forward to working with. As you mentioned, PEPFAR has worked in the HIV space, and I know that that's the silo that we have to break beyond. And I think with the UHC plan and primary healthcare plan, we really need to identify how to break those barriers, because I think we also see that as people who are living with HIV are on treatment and living longer lives, they're starting to experience other health problems as well, like diabetes and heart disease and cancer. And we need to ensure that those patients have the ability to transfer out of the CCCs and get the health services they need within the broader health system. And even better yet, at some point, that health system should just be there for everybody and not so focused on those silos. So I think we've got a lot of work to do in that arena, but I think we're getting there. PEPFAR has developed a lot of health solutions for the HIV patients that are there, particularly on, we call it person-centered solutions. We have a app that's a Nishairi app that helps the patients track their status over time, tracks their appointments, tracks lab results, and also if they're having issues, it helps connect them to case managers. And I think as we look at how we work within the broader health system, I think a lot of those systems and these apps are really applicable to other diseases, and really we can work to get there. On the community side, I think it was really on the video, we saw a lot of the apps that are being used, like Afiastat, Aegis. There's DREAMS applications for our adolescent girls and young women. We're also developing applications for community-led monitoring so that that community groups can actually go out to facilities and help provide input to the facilities, to the counties, and to the national government on how to do better for the individuals that they're actually serving. I'm looking forward to getting those rolled out. Some of them are there, some need to be. At the facility, we're also, we've helped roll out the Kenya EMR as has been described. There's ARMS and there's eCare, and I think what we need to work on now is how those actually work together and go beyond HIV, and really how other diseases can work in that space. We've also worked on mHealth solutions like Ushairi, mLab, and referral directories to kind of bring together the disparate directories and databases that are out there, which again, applicable to beyond it just HIV, but I think we've started there, and we are working with the Ministry of Health to really identify how to do that. And there was a conversation I had this morning actually with a CEC from the governor's county, where we're, she and I were really talking about, okay, how is this applicable, and how do we make sure that as the national system is set up, that the counties are using it and that the facilities are actually using it. And the reality is the transparency in the system needs to be there for them to be able to use that data themselves, and to make decisions and to understand how to use their resources as best they can. And then that also needs to translate down to the individual as well, and how they can pull their own data and understand and determine how their data can be used and hopefully be protected. Because I think that is a critical piece. We're moving beyond to look at digital health intervention progress, and really right now we have about 98% of ARV patients that are in sites that are using the EMR system, and we've been able to identify 90% of those within the national data warehouse, so that we have a better understanding of exactly how many patients we actually have, where they are, and also we can have a better understanding of when they move from this facility to that facility. And I think that we've got some more work to do in terms of developing and understanding what the master facility list really entails when we move beyond just the HIV spaces. We've worked with community and client registries as well, and we're also supporting the HRIS system so that we can track healthcare workers that work with HIV, but hopefully that'll be translated beyond as well. We are also working with machine learning to identify some of the efforts that we need to understand risk for individuals who are on treatment, so that if they are, if they have risk for coming off of treatment, if they have risk for viral suppression or for non-viral suppression, and also for mother-to-child transmission, we're using machine learning to understand that and really identify those individuals for specific care to be followed up on. And then lastly, we're looking at long-term sustainability of the program and really that integration piece that I think is going to be really critical. And so we're working on how to integrate HIV into the PHC so that it's a broader perspective. It's going to take some time, but like I said, I think that it's really critical for us to understand how to use these efforts so that and I think we've seen a lot of the systems work that PEPFAR has done has really been useful across other diseases. We saw it in COVID-19. Here we've had Ebola on the doorstep in Uganda this year. We've had yellow fever. We've had about 5 or 6 outbreaks of different diseases in Kenya that we've all had because we were able to use the lab system that we helped the government put in place. Those helped. It helped to really keep them from growing beyond what could have been a disaster. So my last piece is really talking about that data transparency, to come back to it, because I think it's really critical for us to be able to use it. And once people actually start seeing the data that's in the system, they actually have a stake in the data, and it starts actually getting to be better data and more reliable data because they see the reason for putting it in and they actually use it on a daily basis. Pause there and thank you.
Oh, thank you. Thank you so much for those insights. We can see, from paper-based systems to now even exploring machine learning in the initiatives to just impact positive health outcomes. The 20-year journey has just begun. There's a saying that says, the last shall become the first, and the first shall become the last. So in that regard, I would like our panelists in one sentence, just in their capacity, what is their commitment to digitalization as the audience is getting ready for a question? As you prepare your questions, Katra will guide on how many there are. Please make sure you say who you want to answer that question. Very quickly, just one sentence, what is your commitment? Then we'll just move along.
Person-centered digital programs to help break beyond the disease-specific barriers.
Thank you. For UNAIDS, actually, we are saying that we can work to ensure that digital health initiatives reach marginalized and unserved populations, including those that are affected by HIV and AIDS, through advocacy.
For ICRH, scaling up the digital health solutions, specifically in the space of commodity supply chain across all the 47 counties. Right now we are in 16, but we are hoping that by next year we should have covered all.
Okay, for Christian Blind Mission, CBM, our commitment is to strengthen healthcare systems on issues of inclusion, in particular focusing on 2 innovations around use of peak technology in eye health screening, referrals, tracking, and client management. And then secondly, modeling 3D printing technology around rehabilitation services and then scaling up its use. Thank you.
For AMREF Health Africa is to remember that behind each data point is a human being, and that we will work with all the stakeholders to ensure that we're not just focusing on the benefits of digital, but also safeguarding digital and data against unauthorized access, so that we protect people from discrimination, stigma, undue influence, and profiling.
For KEPA and MTIBA, leveraging technology so that we can support the county governments and also the national government to provide access to quality healthcare for all Kenyans.
Yeah, thank you. From the ministry, mine is to say that this is a very good public participation forum. We've heard you. And as government, we are working to provide the required policy guidelines that will take care of the things that you've brought up as a panel. I've had many buzzwords: data protection, end-to-end visibility, data quality, protection, learning from the lessons that we have seen from previous systems that we've had. We just that. Thank you.
Thank you. And for counties, it's to prioritize digitalization of healthcare by making investment within our budgets, but also building partnerships with national government and private sector to advance digitalization.
Thank you. Thank you so much, Chair, for completing those commitments. Next year, same time, Katra, you will hold each and every person here accountable to their commitments. Thank you so much for your time, for all these wonderful insights. I don't know if we have questions. Yes, there is a question. Please do allow just for a couple of questions. Please state your name, be very brief, and just who you're directing your question to. Thank you, just in the interest of time.
Thank you so much. Good evening, colleagues. My name is Josephine Odanga. I work with the UNICEF Kenya Country Office. Maybe just to indicate that as UNICEF, we're also supporting ministry at national level on digitalization of healthcare systems on various components. Dr. Sirengo, KQMH, Dr. Laura Angwenyi is currently working with your team on that. And also on supporting the setup of a repository, electronic repository for immunization, a system strengthening, together with the Jomo Kenyatta University of Agriculture and Technology. My name is to Dr. Sirengo, who's a long-term friend. Two things. One, listening to the different panelists, I think there's a lot of work, Dr. Sirengo, that ministry needs to do, just for your consideration. We want to develop policy while county governments are already running with digitalization. And I think we have the risk of really having the county governments, have perhaps having some breaks so that they do not proceed so much. Because yesterday, listening to Kisumu County, it was M. Marwa. Today here it's MTIBA and of course a lot more. And of course counties are the implementing wing. So I think we really need to move with the haste, speed, so that we are able to have the necessary policy standards and guidelines to actually shape up the digitalization of healthcare systems. Why do I say this? Because if Governor Wanga, who is my governor, I'm actually a resident of Homa Bay County, if she has to move so much and then find out that ministry has perhaps totally different guidelines, it will actually throw her off guard. So what I was thinking, Dr. Sirengo, for your consideration, we are just starting work on the development of the Kenya health sector and investment strategic plan. If you, your team at ministry headquarters, working closely with counties, may consider actually embedding the digital health systems into the health sector strategic and investment plan, so that at the stage of situation analysis, we are able to take stock of what UNICEF, other partners are already doing. as part of situation analysis, it will actually help you, Daktari, in actually shaping up the policy, dialogue, and also the standards and guidelines, as well as the community health units, dispensaries, health centers, sub-counties, counties, actually including digital health, components into their annual work plans. And then finally, kindly consider calling partners really for a forum so that you are able to actually generate actually map the different sets of digital platforms that are being supported by the different partners at the moment, so that as we give guidance to the counties, we'll already be talking of what other partners are doing and perhaps proposing to counties if they could actually use some of the innovations just as part of Scale Up. Thank you.
Thank you. Thank you so much for those perspectives, and I'm sure, Dr. Sirengo, you've taken note of that for the humble consideration of the ministry. Yes, a question from the lady in pink, and then followed by the gentleman in a red tie.
Thank you. Mine is not a question, it's a comment. My name is Dr. Nelly Bosire. I'm here with the Kenya Pediatric Research Consortium. I think for me, it's just to take note that I appreciate how much technology is going in linking the patient to care. I really appreciate the fact that there's something coming up addressing commodities. But I would like to see better on services on the ground. What technologies can we come up with that link Governor Wanga's facilities from the level 2s to the referral level that talk about what service can we offer now? How do I know your theater right now is broken down because maybe there's a machinery that's not working, and we stop wasting time in the referral chain, coming there to be turned around to head elsewhere. I think that too would be very beneficial. I would also like us to acknowledge that we, a lot of the times, think that patients just want to go to level 5 facilities to get service. But truly, if you go to the villages, they want their level 2. They know the nurse there by name. She delivered the past 3 babies. She knows where they live. They have a relationship. So as we talk about technology also in terms of medical equipment, we see a lot of investment, and even when we see our leaders talk, there's a lot of emphasis on we have a CT scan machine, now the MRI is working. I want to hear for PHC to succeed, for us to start bragging about how amazing our level 2s and level 3s are doing, because that's where PHC is centered.
Thank
you.
If we
can be able to do that, I think we can be able to win this. Thank you.
Thank you. Thank you for those comments and that feedback. The gentleman in a red tie, then we'll come to the gentleman in a red shirt.
Thank you very much. My name is Dr. Andrew Muruka. I work for the Ministry of Labor. I have 2 questions, I think, for Madam Rita. The first one is that, is it possible to develop digital solutions to manage congestion, particularly on the lines, when you are going to hospital? I mean, I don't have to go to a very crowded hospital. I should be able just to know that this hospital is crowded, maybe I should go to this other one. I mean, something like that, so that workers in particular spend the least time in the hospital, then they spend the most time at the workplace. That is number 1. Number 2 is it possible also to develop digital solutions for bed management? Beds in hospitals. Sometimes you go to hospital, you leave your bed, you are admitted only to go and share a bed with another person. Is it not possible that you're able to, just like you're able to get information about a booking for transport from one location to another, if you want to use a bus, you should be able to check whether there is availability of beds wherever you want to go. Thank you.
Thank you so much, Dr. for those questions. As Rita, you're ready to answer? Okay, we can take one more question and then go to Rita to answer those 2 questions. Yes.
Thank you. Thank you, and good evening.
I'm Patrick Adera, work with Living Goods. My question would go to Her Excellency Governor Wanga and Daktari from the ministry. And my question will be a bit biased towards community health strategy. We are talking about digitization of community health and having CHPs work on a digital platform. My question is, what are the plans to make sure that these CHPs are well equipped, they are well supervised, and they are well compensated? Because having digitization without the other pillars having been fully addressed, then I don't think the end game of making sure that service is delivered will not be appropriately addressed. I'll be very happy to hear what the plans are. Thank you.
Thank you so much. Those two questions are for the chair and Dr. Sirengo. Yes.
Thank you. My name is David Kirui from Nandi County, working for Eastern Produce Kenya Limited as a private sector. Mine is a kind of a compliment, though in a different way. This goes to our Excellency Governor Wanka and Dr. Sirengo. I've heard when the regulator was asking, next year we will ask the panelists, what have you done? But mine is going to be like, why don't we have a timeline so that we give ourselves 6 months and we have emails nowadays. As you talk about digitalization, we have emails. We should leave us with the emails so that by end of 2 months, we write to you, Dr. Sirengo, how far you are, Madam our Governor, how far has the county government have done. Thank you very much.
Thank you. Thank you so much for that. Another question. Wow. So the gentleman at the back, the lady here, and the lady in white.
My name's Joel Rugut from Wasingishu County. My question is, when we went for digital in education, it really didn't work. I don't know if we go digital in health, is it ready to work? Because the question goes to Wanga and Sirengo, the national team. You realize that our daily data that we are taking in our hospitals, we normally give data at the end of the month, but we don't do it on daily basis. So I'm very worried if we can really achieve that. Thank you.
Thank you. Our session chair and Dr. Sirengo seem to be really in the hot seat. You can go ahead.
Thank you. My name is Mercy Kilel. I'm a nominated MCA from Nakuru County. My name is Mercy Kilel, a nominated MCA from Nakuru County, and my question is to Her Excellency Governor Wanga, so far my favorite governors. I want to ask, what are your policy directions that you've taken as a county as far as HIV and reproductive health goes? Noting that your county and even Nakuru is among the highest rated in terms of infections and reproductive health challenges for women. Thank you.
Thank you so much. The lady at the back, then the lady in specs, yeah.
Thank you so much. My name is Nerima Wanyama. I am from Busia County, but currently living in Nairobi County. And I'm glad that she asked that question about HIV and pregnancy, because my question is sort of related. It's an open question, although I would like to put the governor and Dr. Sirengo on the hot seat one more time. In everything I've heard, a lot has been said about HIV and how digitization is working for the HIV sector. However, HIV as it is it compromises the immune system, and some of us come from counties where malaria is a very, very huge problem. Is there any current intervention in the ministry, in the counties, in Mtiba, for example, where there's integration of that kind of information? So someone who goes to the hospital with malaria symptoms, there's active data, live data that says, oh, they are HIV positive, this is how far they stand, they recently tested positive for pregnancy, this is how old they are, etc., etc., etc. It would be interesting to have that information available so that we know what needs to be done to save lives across board. Thank you.
Thank you, Nerima, for that. The lady in specs, then the gentleman, and then the lady in brown. We will sleep here tonight.
Thank you very much. My name is Mary Mwami, and I work for African Institute for Development Policy. And mainly we look on issues to emphasize on use of evidence, generation and use in research, and also in decision making. My question goes to Dr. Sirengwa and Honorable Gladys Wanga. Because when you look at data, we keep on talking of digitization, but the aspects of data that in access, there are so many organizations. We have development partners, we have different organizations that carry out research. There's a lot of data that is out there, but are there plans by which maybe the ministry have a way in which they want to integrate these data such that when we want some information, like what we have with WHO, they put in so much data so that in case I want any information, I'm able to get it from there. But all this data that is maybe at county level, at the national level, how are there any strategies maybe to have a repository where if I know information on health, I can access it at this point? Are there any plans, and if there are any, probably where are we at? I remember during the high-level dialogue, there was an indication that we need to embrace strategic purchasing so that we can use data. So this data that is all over, we have organizations like KNBS, we have KIPRA that has a lot of data. Do we have plans for putting all this data together that we can access it real time?
Okay, thank you. Those two last questions, please keep them just one sentence, and then to the answers we'll start with Rita, then we go to Dr. Sirengo and Honorable Wanga.
Good evening, all. My name is Richard Kihara Kabiru. I work at National Cancer Institute of Kenya. My question, I would direct it and put it in short. Through the ministry for the digitized platform, how are you interoperability towards NCD cases, in this case, the cancer learner or cancer data, to the National Cancer Registry? On top of that, I would like to maybe to the panelists that make aware that we are digitalization in terms of M-Salatani as National Cancer Institute, and also we are trying to do a digitalized patient navigation method for the cancer care. Thank you.
Thank you. And to the very last question, just one sentence, please. Then we go to the answers.
Good evening, everyone. My name is Dr. Darlene Evans, and my question is to Dr. Sironga. How are you, in the wake of digitalization of healthcare, how are you helping us as doctors to be able to have a registry or a transfer of health history of our patients? Because a big issue we have is when a patient goes from, say, Mombasa to Eldoret, and the history is so long because they have diabetes or hypertension. They probably also have age-related dementia. They can't remember some of their history, and they have no family member, and I don't know what exactly they've been through through the health record. So health history transfer. Thank you.
Thank you, thank you. Wow, you guys are just, you rock, you're amazing. You've been paying attention, you've asked so many questions. We'll start with Ruth, then we go to Dr. Sirengo, and finish up with our chair.
Okay, I think there were two questions asked. One was around digitizing queue systems. I think that is possible. Queue systems do exist. And the second one was around the digitization or transparency around bed availability. That is also available. But both of these are subject to what we've been talking about here, which is interoperability between hospitals, the Ministry of Health, and all facilities, so that there is a national database or even a county database that can be easily accessed, not just by the health professionals in the ministry, but also by the public. So maybe Dr. Sironga can speak to that and how that ties into the health management plan. But the digitization and the quick availability and ability to see is definitely available. I will request that my CEO who is here takes any further questions from me, because otherwise I will probably miss my flight. I beg to be excused, Madam Chair.
All right, thank you very much. I have all the questions on behalf of the panel. So I'll go one by one and try to do that very quickly. I think the first speaker made more comments than questions. I noticed she's actually left the room, but she was asking that it would be nice for the ministry to constitute a forum where whatever is going on in the space of digitization in the whole country can be discussed and actions therefrom acted upon. Yes, I can't agree more. I think that is a good suggestion, and we can work on that. Now, alongside that, there was a question about how comes the ministry is lagging behind in formulation of policies, and yet counties are going ahead with so many digitization innovations and actions that are going on. In my remarks, I did mention that as a ministry, our job is to make policies, and towards digitization, we have, number one, started the journey of putting together guidelines and standards that will regulate the use of the different digital platforms that are currently happening. For most of you, I know you understand that as a government, we cannot pick one innovation from a certain corner and make it a recommendation for the country to follow. We use evidence-based programming and research findings that are of very high quality to inform our policy guidelines. And so we want to encourage those innovations happening in the counties to continue, so that then together, when we do pooled review of the evidence, we can say, yes, these innovations work, and we recommend that that's the way to go. So that's the process. So you should not feel discouraged that the counties are doing things and the national government is watching. It's part of the process, and we encourage that. There are three questions that were linked that I want to answer, all of them in one breath. One question was asked about technologies that exist or are being worked on to link level 1 through to level 6 health facilities. I think this came from Dr. Bosire. Mr. Odera, you also asked what is the digitization plan for community health strategy? And I think David also asked about the timelines. In my remarks, I think I did not mention it, but it's part of what I'm supposed to say. Currently, as we speak, UHC is on the top agenda for the Minister of Health and the Government of Kenya. In fact, as a matter of fact, the patron of UHC is His Excellency the President. And come October 20th this year, you are going to see something happening in terms of a big launch for UHC. And towards that, the ministry has already started the journey to get us there. Last week, our cabinet secretary launched a health facility census sort of assessment to look at the level of services that are available from level 1, which is the community, to the dispensaries, to the health centers, and up to level 4, so that we are able to map the community primary care networks for purposes of delivery of UHC, so that we know in this ward, for instance, we have this kind of services, these facilities with this level of services in terms of infrastructure, in terms of equipment, in terms of human resource, so that when the community health promoters do their work and refer patients, they're doing that best on the available services. They're not guessing. And to facilitate the community health promoters, the national government, together with the counties, through a co-funding mechanism, are going to equip the 100,000 community health promoters with mobile gadgets that will be able to collect data for individuals at the household level, not just sicknesses, but health and wellness data, so that in every community health unit, the supervisor of that community health unit is able to say that these are the predominant conditions that are in this ward of mine or community health unit, and therefore link them appropriately to the services. So the journey has begun. It may not be as fast as we want it to be, but we will surely get there. Okay? Then there was a question, I hope that answers the issue of timelines. Yes. And then there was a question from Nerima on the plan to integrate information so that, and she used the example of HIV and malaria and pregnancy. Yes, this is what we are working towards, to the point that when we have what we call the digital superhighway, all the digital platforms for different disease entities are linked into one. So that if a patient goes for one service, they should actually be treated holistically. It's a time I think we need to move away from the parallel programming that we've always had. And the truth be told, the parallel programming was good for efficiency of the emerging diseases at the time. With what we've learned now, we are going to have all this in one place. Okay? And that also should answer the question of patient data migration. I think it came from the last doctor there. We have had this discussion for very long. There's nothing as annoying to a patient like repeating yourself too many times every time you see a different doctor, especially if you have chronic disease. You're here in Eldoret, you walk here at MTRH, you say your story, you're given medications, and probably you live here. When you travel or migrate to Mombasa, you repeat the same story. And you may not be consistent. Your treatment history is lost. And so this is where the unique identifier discussion has been happening. At some point, we were excited that the Huduma number was going to help us out on these things. Probably the answer is yes. Once we have that, then it's possible for us to have that information transferred through an operating and efficient health information system. One of the concerns, of course, has been the issue of confidentiality when it comes to that. Some patients in HIV program, for instance, they're called Martin and Eldoret. They go to the clinic once, they meet Liz there, because I duck, I go to Nakuru, and I become Fred. So those are some of the issues, intricacies that we have to deal with. My last question, I think, to respond to is what we are doing to integrate non-communicable disease data. And the answer is just what I've said, that once we have the digital superhighway, a one-stop shop for all the digital information, all these different entities, different data platforms should feed into that. And we can be able to access that information, both for patient service delivery purposes, for reporting, and even analytics for decision making, for us to say, where are we coming from, where are we going, where can we invest more? Thank you.
Thank you, Dr. Sirengo. I think you have answered a lot of the questions that we were asked together. So I will just make maybe one or two comments. One, I wanted to associate with the comments of Susan earlier. Dr. Susan, who said the national government must speed up and bring to scale these things that we are doing. You know, Dr. Sirengo, we can't talk here forever. We worked with you in ASCOP. Now I went to Parliament for 10 years. Now I've become governor. Surely we are still talking. These things, they are still coming. They are coming slowly. And that's why David was saying, give us timelines. And I agree with him. Let's agree. You know, this one we have to do by this time. This one let's do by this time. And we bring them to scale. They can't be pilots forever. So I wanted to just associate with that comment. And since you are my colleague, you won't feel too bad. And I also wanted to agree with Dr. Bosire on the issue of patient-centered digitization. Digitization should respond to the needs of patients and help the patients to take care of their needs. And in Homa Bay, we are a people-centered government. So we are very interested in what does this mean, not just for us and for us feel good, look good type of stuff. What does it mean for the patient who's coming to our facility? And sometimes because of infrastructure, internet, technology, and this digitization, it becomes a hamper instead of a facilitator. People sit there on the line, oh, internet got lost, we are still waiting, I don't know, for this or the other. So I wanted to associate with those comments and then just come and say, you've already answered to the community health strategy. I think what our Living Goods friend was saying was, you know, you're giving these people laptops, now they're going to be carrying big baskets, big bags. Are you equipping them? You've answered it. From October, we are partnering to make sure that they are. Most counties are now paying stipends, and the national government is going to come in to double that and so on. So, watakuwa sawa, you know, as we go along, and we are thinking about them and supervision and so on and so forth. So, David, I wanted to agree with you on timelines, and I wanted to agree that let's come back and ask ourselves those hard questions. And for counties, I think we will have a conversation around how do we move. And I think for counties, because we have a very short time, we are on short contracts, so we must, you know, show results within a certain space of time. I don't know whether you answered the question by Rugut. He said, why do we think digitization in health is going to work? It failed in other spaces. I think we are convinced because of some of the issues that have been raised by our panelists here, the steps that we have made in terms of just digitization in the various aspects of our lives. I think people are more and more using technology and adopting it, so I think we are optimistic because of that. For the final two questions that I think have not been, you know, covered and said by Honorable Kilel, thank you for the kind comments on HIV and reproductive health. We bear a very heavy burden of HIV and teenage pregnancies and sexual and gender-based violence. We're doing something about it. Together with the issue of integration, I think you have HIV and, you know, NCD integration or malaria and so on and so forth. I wanted to ask Rosalind to say, just in 1 minute, on the two areas of what we're doing around the triple threat and what you have, you know, very strong views around whether people should just go to CCCs in a corner. And I think we are having discussions with PEPFAR now around integrating because people are living longer with HIV. They're now getting diabetes, you know, malaria and other things. So I think we are having some. So in 1 minute, Rosalind can just summarize that because many of us don't know Eldoret very well. We don't want to walk in darkness. So, yeah.
Thank you, Your Excellency. As Brian said, this is one of the discussions we are having in the morning because the EMR is working perfectly for information and tracking of HIV and AIDS patients. But as we know with all diseases, there's also mutation. So the example I gave is when I walk into a hospital and I'm expectant. Maybe I don't even know I'm expecting. So I'm vomiting in the morning and I'm feeling feverish. Then I mutate to pregnant. Then I mutate to HIV and pregnant. So there's also the issue of mutation. And what I was saying is we need to track the patient rather than anything else. Then that way we shall know. And that's what we are doing in Homa Bay, as Her Excellency said. We are people-centric. So we are running a pilot in 2 of our facilities. This also goes with the triple threat, adolescent and teenage pregnancies. And it's also very unfortunate that most of adolescents and teenagers who get pregnant are also HIV positive. So for us, it's a reality that we live in. It's not like we are separating, we are not piloting, we are now just working to crystallize this and scale it up. And lastly, Your Excellency, somebody asked a question on data and asked, why don't we have data in one place? Data is mined for different reasons. The reasons that are mining data might not be the reasons that AMREF is mining. The same data from the same person. So we also have to talk about and consider the volatility of data, and especially health data in regards to what I've said. As counties, our data adds up to Dr. Sirengo's national health data, but he wants it in pillars. He wants this information under 15, mothers, under 19, over 20, and so on. So yes, we are working towards that crystallization and ensuring that we have a one-stop shop so that our patients are able to know what they are suffering from. Thank you.
Wow. Thank you so much, everyone, for your contributions, and most importantly, for your time and for your engagement. This is one of the most engaging sessions I've had the privilege to moderate. So thank you so much for such a vibrant audience that we've had. Thank you so much, panelists, for your insights, for your time, for your commitments that will hold you to. So asante sana to everyone. I just have 3 announcements. One is the panelists, please just 2 minutes for a quick photo with just as a panelist and as well as with the secretariat. And then Katra and her team have invited everyone for a dinner at 7:30. Thank you so much. It's right at that tent, right adjacent to us. So again, I can't say thank you enough for your time, for sitting here, for listening, for sharing your insights, and for the call to action and the commitments. Thank you so much. Kwaheri.